Now let us go to one of the major trials, that is the Pioneer Heart Failure Study. Now what did the Pioneer Heart Failure Study was done in acute decompensated heart failure with ejection fraction of less than 40%. 881 patients were included, and these patients were stabilized while still hospitalized. Now what do we mean by stabilization? That is, the systolic blood pressure should be more than 100. There is no increase in IV diuretics. There is no IV vasodilators or no IV INR drops prior to the patient being randomized. They were randomized into two arms. The sacubitril valsartan arm, the target was to go up to 97 versus sacuval to up to max of 100, that is 97 by 103 milligram twice daily, and the enalapril arm was up to 10 milligram twice daily. So these were all in hospital randomization, and the blinded treatment was for 8 weeks. Now what was seen was that when the results were analyzed, it was seen that the heart failure hospitalization patients with ADHF, the results in the sacuval arm was much better than the enalapril arm. What was seen that if you compared the change in NT-proBNP from the baseline percentage, it was seen that the NT-proBNP started falling as early as 1 week of randomization. The fall was much significantly higher in the sacuval arm compared to enalapril. The next aspect that was seen was the cardiovascular death and hospitalization. As you see, the two graphs start widening as early as 1 week, and the sacuval arm or the ARNI arm did much better than the enalapril arm. So this enlightens two facts, that as if you start ARNI as early as possible, the results are visible within 1 week. Let us try to analyze what are the type of patients that were included in the Pioneer Heart Failure Study. The majority patients, that were 41% of the patients, were worsening chronic heart failure patients who were either on ACE or not on an ACE. Now de novo heart failure patients constitute the next subgroup or the maximum subgroup, were around 25 to 27%. Some were on ACE inhibitors, some were not on ACE inhibitors. So it was seen that the change in NT-proBNP after 8 weeks of treatment was best seen in patients with de novo heart failure. So that is, if a patient comes to you with acute pulmonary edema or with left ventricular failure without any previous history of heart failure, you have every right to start this patient on the ARNI based on the Pioneer Heart Failure trials. It was seen the change in proBNP at 8 weeks was very significant, whereas worsening chronic heart failure or those on ACRB or without ACRB also, it was seen that ARNI did better. But if the patient was not started on ACRB and you directly start with an ARNI, it was still the results were much better. So this should give the take-home message and the confidence based on the Pioneer Heart Failure Study that early initiation of this thing, that is ARNI, does improve the clinical outcomes, and this has been as per the ACC 2021 guidelines. Let us try to analyze that if these patients did not have an exposure to ACE inhibitor ARB and you put them on an ARNI, the same type of phenomena was seen, that patients who had a change in NT-proBNP was higher in the ARNI arm compared to the the enalapril arm. And similarly, the incidence of cardiovascular death and hospitalization and heart failure was much lesser in the ARNI arm compared to the enalapril arm.